Association, is the Brickhouse Professor of Surgery and Chairman of the Department of Surgery at Eastern Virginia Medical Center, a recent President of the College and Chair of the Board of Regents. LD, thank you very much to come and talk to us about the ACGME perspective stance on duty hours.
Well, Dr. Hunter, I know that that this is a very important session. I will keep to my 15 minutes because I think the important component is obviously getting feedback from the audience. I do want to recognize also Dr. Britt, and also want to recognize the organization. SAGES has been a wonderful organization tackling some very controversial issues. But I have no conflicts, nothing to disclose. I do want to be transparent. I'm giving a talk on ACGME, but I'm not a member of the ACGME now, as far as I'm no longer chair of the RRC. I do want to thank Dr. Sachdeeva. He is stepping down from his role as ACGME. He finishes his term on the board, but we have to commend him because I can tell you things might have gone a different direction had he not been on the ACGME, so I want to thank him. Also, in the spirit of being with full disclosure, Dr. Stain is currently on the RRC. So if we talk about RRC issues that you're concerned about, I want you to look at him and not me. Also, again, in all fairness, I had to wonder, why did I get this topic with no ACGME connection there? We have Dr. Rick Green in the audience. We have Dr. Mavi, who's a director on the board with me, and obviously Dr. Nada, who's been a program director. But maybe they always give me the controversial topics. So let me start. If you look at what we've gone through, again, my talk is supposed to be on workout limitations. And looking at this slide, you can see how we are getting closer to some of our other international colleagues, and I think that will be a mistake. But what I would like to focus on, I think I would be remiss if I did not use my 15 minutes to talk about the Next Generation Accreditation System, what they're calling NAS. This report just came out a couple of weeks ago, and it really is a report that we really need to look at because this will start July 2013. And as you see here, the ACGME, the accreditor for GME, serves the public, and that is true, by setting and enforcing standards that governs the specialty education. And for those who don't know the landscape of the ACGME, there are 27 RRCs. The first RRC was the RRC for surgery, and back in 1950. You have 26 core specialties and 115 subspecialties. So it's a big landscape. Currently, if you look at what we do as program directors, and I'm a program director, we have a prescription program requirements, and it is prescription. There's really no real environment for innovation. I think most people would agree with that. There has been increased administrative burden. We are now managing programs versus mentoring residents. I find myself managing the programs more than obviously mentoring residents and trainees. Educational standards, in my opinion, have lagged behind the delivery system changes. And I don't need to tell this audience, there's no real funded support for some of the initiatives coming out of ACGME. Now, the aims of this NAS, which is the new accredited system, is to enhance the ability of peer review system to prepare the physicians for the practice in the 21st century, and this all is very laudable, to accelerate the ACGME's movement towards accreditation based on education outcomes. I think we all want that. And then the third aim of NAS, and you'll hear more about this, is to reduce the burden associated with the current structure and process-based approach. Expectations. The expectations of this NAS is to, obviously, physicians to function as leaders and participate in a team-oriented care. And I agree with this, information technology literacy, because we're not quite there yet. Sensitivity to the cost-effectiveness of what we do. And obviously, the ability to involve patients in their own care, and the use of, obviously, IT to improve care. And as I mentioned before, for those who haven't heard about this, because this just came out, this will be implemented July 2013, so in several months. But it was just for 7 specialties. It will be emergency medicine first, then internal medicine, neurological surgery, orthopedic surgery, pediatrics, diagnostic radiology, and urology. And again, the reason for not NAS is that they really felt that currently, and it is, ACGME is really more of a biopsy at any given time as far as the annual collection data and looking at it. And the NAS now will say that you will have annual data collection. Emergency medicine, my emergency medicine program has already started this. They have a 10-year cycle. Programmatic self-study. There'll be elimination of the PIF, which is the only thing I can really applaud on this. There should be emphasis on educational outcomes of the program, and then you will have a 10-year site visit. And that will be all the programs. And the key element, the paramount element of NAS is the measurement and reporting of outcomes. And I embrace this. And I'll tell you what I feel is the downside in a minute. My job is to represent ACGME now. The programs of NAS will submit composite milestone data that a lot of the ABMS organizations have helped design on their residents every 6 months, with residents obviously synchronized with resident semi-annual evaluations. And again, the overall aim is to create this logical trajectory of professional development on essential elements of competency, and obviously meeting the criteria for effective assessment. And the final milestones will create an entry point for maintenance of certification and obviously the licensure phase of lifelong learning. Now, the emphasis, they're going to put an emphasis on institutions, obviously, for quality and safety of the environment. So they're going to visit the institutions more frequently, in my opinion. But you're not going to have to go through, obviously, the short cycle site reviews. And the milestones, and this is a template. This is a template milestone. And you can't read it. I don't want you to read it. But every level will have to be able to meet this for the various specialties. So each RRC will design, along with, obviously, support from the board, and support likely from the program directors, will agree on what are the steps, level 1, level 2, level 3, as far as professionalism, as far as interpersonal and communication skills, as far as practice-based learning and improvement, and as far as system-based practice. Now, there's no doubt we're going through a renaissance, and one could ask, will this actually help? Let's go back. Now I'm going to somewhat step away from my representing ACGME. I do feel you should read this article. This article is authored by Dr. Naska, Tim Flynn, and I forget the other two, but that was on my first line. If you look at the quality control mechanisms of graduate surgical education, there are 3, in my opinion. There are 3 quality control mechanisms. One is the RRC, which I just went through, but one that's forgotten is obviously the American Board of Surgery, but also the college. Other countries don't have this. They have one organization that really is the control mechanism. The Royal College of Surgeons of England, they do it all. They accredit, they obviously educate, and they certify. Doing a critical analysis of this NAS, and that's what I want to spend my few minutes on, we need to be able to look at the data that's generated by this. We also need to look at what the metrics will be, because I'm not sure that the metrics will be something that we will all be able to embrace. But at the end of the day, we need a checklist for NAS. NAS is something that could either be a home run or it could be a disaster, in my opinion. First, will educational objectives be met? That's probably one of the first things Dr. Sachdev will say. Are we going to be able to meet our educational objectives? Number 2, with this NAS, will there be specific metrics? Because I haven't seen them yet. Yes, you can talk about these template milestones, but they're generic at best. Will the logistics, I want my program directors to hear this, will the logistics of tracking this, remediation for people who don't meet the milestones, the possible resident retention, will this be burdensome and cost prohibitive? My feeling is it likely will be for some programs. And can these milestones be accomplished? And I'll go back to duty hours now. Within the duty hour limitation, that's going to be key. And the question, which I think is the hardest question, will all these innovations, particularly in NAS, dictate improved patient outcome? Because currently we have not seen that with some of the changes. And then the last thing is, do we have the resources? Do we have the resources to be able to fully implement NAS and participate in the Next Accreditation System? Well, that's a lot, and I can't wait for the Q&A. Again, we are overhauling residency training, there's no doubt about that. But I'm going to go to something where I was there a few months ago. I was at the Royal College of Surgeons of England. That's when John Black was the president. And this came out while I was there. Now let's go to the last line. This is his quote. He had the same concerns I had when they changed the system in England, but they didn't have a choice because it was government imposed. It is a matter of regret, for those who can't see it in the back, I'll read it for you. It is a matter of regret that all the adverse effects that we predicted have come about. I hope we do not say this. I won't be president saying it, it'll be somebody else saying it. I hope this will not be our quote when all these innovations come out. So with that, I hope I represent the ACGME, but I wanted to give you some commentary on my side. I'm looking forward to the Q&A. Thank you very much.
Thank you very much, Dr. Britt.